Well, hello, everyone, and welcome to today's webinar. My name is Dawn Van Dam, and I'm the president of 1 Million Solutions in Health. Today's webinar is called Advancing Genomic and Pharmacogenetic Medicine, and this is taking off on President Obama's recent announcement about his precision medicine initiative. So we're very excited to have today a very terrific speaker, and I'm just going to jump in and tell you a little bit about us and then about Dr. Palais, our speaker for today. So at 1 Million Solutions in Health, our goal is to improve healthcare one solution at a time, and that is in the areas of life sciences, healthcare, and for patients and consumers as well. We have a lot of ways that we help you do this, and sorry for the slide being a little bit out of alignment there, but we help you connect with other people around the world. We help you learn and share about different things through events, discussion forums, articles, webinars such as this, and our real goal is to help bring innovation to market even faster than it has been. So our passion is to accelerate the adoption of science. So if you registered for this, you probably know a bit about the background for today's discussion, but Dr. Arnold Palais is going to be talking about what it means for us as in the medical community, what it means for us in the scientific life sciences community, and therefore for patients and consumers with this new push into what is sometimes called personalized medicine, and in Obama's recent State of the Union address is called precision medicine, and how the $215 million will help accelerate things a bit, but there's a lot more to come as we move forward. So let me just give you an introduction about Dr. Palais and his background. So Dr. Palais is the founder and associate director of the Jacobs Levy Equity Management Personalized Genomic Medicine Program at Atlantic Health System. And there he practices, lectures, and champions issues in genetics for physicians and patients alike. He has spoken nationally on topics in genetics, oncology, and primary care, and teaches genetics for medical board review courses. Dr. Palais has a long-standing interest in genetics in primary care, particularly in the area of cancer predisposition, prediction, and recurrence scoring. Dr. Palais is a board-certified family physician and has been in private practice in Montville, New Jersey since 1986. He is a founder and medical director for Vanguard Medical Group, a 6-site regional primary care practice, notable both locally and nationally as a leader in patient-centered medical home. He is the medical director at several area nursing homes and school systems. He has also served as president of the Morris County Medical Society of the New Jersey Academy of Family Physicians, and he is senior delegate to the Congress of Delegates from New Jersey to the American Academy of Family Physicians. Dr. Palais graduated from the Accelerated Medical Program at Boston University, completing both his undergraduate major in history and his medical school studies at Boston University. He then finished his residency as chief resident in family medicine at UMD New Jersey, the Mountainside Hospital. He holds clinical academic appointments as associate clinical professor at both New Jersey Medical Schools and the Seton Hall Graduate School of Medicine, and is vice chair of family medicine at Morristown Medical Center. So with those amazing credentials, and I want to leave no further ado to turn today's fabulous presentation over to Dr. Palais, and just let everyone know that at the end of today's presentation, there'll be a chance for Dr. Palais to answer any of your questions. So please feel free to submit your questions all along during the presentation. And there'll also be a very brief survey that we would love you to fill out towards the end to give us feedback on both this presentation and future events. So over to you, Dr. Palais, and your presentation. Thank you.
Well, thanks, Dawn. Good morning on this lovely spring day in the Northeast, still some snow on the ground. We're going to try to move along and try to help our listeners to get a better appreciation of the world of personalized or precision medicine, which is something that is, you stated, has been really in the news of late, particularly with the initiative that President Obama's administration has put out for $215 million to help bring this forward. So as you stated, it's something that's really important out there. There's a lot of semantics between the word personalized medicine, personalized genomic medicine, and precision medicine. It's pretty much all the same thing, and I'll touch on that more in a second. I do like to start this type of a conversation by really invoking Hippocrates, who said it is more important to know what sort of a person has a disease than to know what sort of a disease a person has. It kind of points us in the direction of personalized medicine, which is really attempting to tailor individual treatments for individualized patients. Now, more recently, we really try to use, when appropriate, genomics testing, and that looks at genes and their proteins to help us arrive at that finding. Genomics and you, I love this from Gerard et al. From the Journal of Law, Medicine, Ethics. Genomics will be to the 21st century what infectious disease was to the 20th century. And really the point of this is that it's no longer just looking at maternal and child health, where many of us in the healthcare industry have been focused on genetics. Now it can be used for infectious disease, chronic disease, occupational health, environmental, pharmacogenetics, which I'll touch heavily on in this presentation. So obviously the role of genetics in medicine has been growing, and obviously many of us understand that we've used human genetics for a great deal of time, and obviously it helps give patients and their families more information about their genetic knowledge. What really has changed more and more is the role of somatic mutation in cancer and aging. Obviously the feasibility of prenatal diagnosis has become a really huge area these days, and more gene-based therapies have become part and parcel of healthcare as we know it in precision medicine. Obviously, genetic services include prenatal, pediatric, adult, cancer, specialty genetics, and then more and more pharmacology genetics as well. So just to get a little fun history, because it is my background, history as well as medicine, the human genome was sequenced by the year 2000 at a cost of nearly $3 billion. There was almost a little race between industry and private foundations. Craig Ventnor and Francis Collins kind of got to the finish line at the same time. And a lot of us like to think that personalized medicine or precision medicine is kind of the dividend of the Human Genome Project. There's several good articles in Science Magazine that really chronologize what happened at the Human Genome Project being sequenced. And sometimes we'd like to have a little fun that this is the DNA matrix and one small step for mankind. So I don't want to get to a whole discussion of genetics on this conversation, but you need to know about the central dogma of DNA, transcription to RNA. That's one of the important backgrounds and backbones of the whole study of genetics. And we are really more and more appreciating the complexity from DNA on the left side, transcription to RNA, and translation to protein. And that's more and more what has been evolving and becoming more day to day. And this graph, for example, is in the New England Journal of Medicine, which really tells you that more and more it's becoming not just a science, but part of the nomenclature of medicine itself. So the graph on the left shows the human genome, and the important highlights of a slide like this is that 75% of the human genome is unique, single copy DNA. Less than 10% encodes the 20,000 or so genes that deal with the human existence, and these are the areas that more and more we are exploring and getting to understand better. Some people don't understand genetics versus genomics, so I have this slide to help you understand. I kind of look at genetics as sort of microeconomics, and genomics would be macroeconomics. So genetics is really single gene DNA, gene-to-gene interactions. These are the classic conditions that we've dealt with in the past with genetics. And genomics looks more and more at expressions of genes using RNA, using one's environment. It can deal with the likelihood of a disease state. So this helps us to understand the two conditions. The more and more focus today has been on genomics as well as expanded genetics using biomolecular modeling as well. Now, personalized medicine, again, same thing as precision medicine. It touches a host of areas from pediatrics on the top, OB maternal fetal medicine, as we've known for a long time, hypercoagulation, the whole area of vascular medicine, drug sensitivity and toxicity, which I'll talk more about at the back end of this presentation. Cardiology has been a newer area of study and usage. Oncology has been well known, more and more research trials, and even public access and ethics. These are more and more important topic that I always like to touch upon in presentations about genetics and precision medicine, because you cannot escape the important bioethics of these areas in these discussions with both medical colleagues as well as with patients alike. So precision medicine really is a paradigm shift, as I like to state. Yesterday, we were all symptom-based, institutionalized medicine. Today, we are looking for pattern-based, evidence-based medicine, and we are moving towards an algorithm-based product or precision medicine. So many people on this call may realize that, for example, electronic health records, which is one of my passions of using genetics, you can look at drug-drug interactions, for example. Well, more and more using genetics, there will be the ability to have some genetics within an electronic health record, and you could then use that as an algorithm-based approach in conjunction with someone's family history and know which are the proper genetic tests that might be actionable for that individual as well. It's really an exciting area in the application of technology to healthcare. Again, paradigm shift, personalizing patient care. Currently has been in the past one size fits all, trial and error, starting low, going slow, and more using pharmacogenetics, we can really derive the right therapy for the right dose, for the right individual, and at the right time. That would be targeted therapy. So just a background, the FDA certainly has supported personalized medicine, learning that trial and error approach can lead to patient dissatisfaction, poor outcomes, and so more and more we feel that personalized medicine is the way to go, and you can read that for yourself later. Even certainly groups such as AMA are supportive of the whole world of pharmacogenetics, not surprisingly, that this is an important area that physicians, particularly medical students, need to become more aware of. It is unfortunate to my mind that our medical students graduating medical schools are really not getting sufficient exposure to genetics, and I think that will change, hopefully, in the very near future. The problem we have is this perfect storm, and this slide I'd like to spend a moment on because really the problem we have is that on average there's one new genetic test added to the market per day. 1 in 5 genetic tests are paid by health plans, and that may be a little higher than that nowadays, but it can be hard to get genetic tests that are appropriate to be paid for by the insurers, and yet 8 out of 10 of patients are interested in genetic testing, but 9 out of 10 patients who want to integrate it into their practice, but only 40% are comfortable doing so. So we have a problem that there is sort of a demand by patients to be more aware of it. There is a difficulty getting reimbursement, and yet many doctors want to but are feeling unsure about how to get genetics into their day-to-day practice. Now, I'm going to delve into a second into the Precision Medicine Initiative that President Obama has unfurled in the State of the Union address. And again, I'd like this to be an apolitical issue because the fact is when this has come to the attention of the federal government, the importance of this, it doesn't matter what your political affiliation is. The fact is that NIH and the National Cancer Institute, the FDA, and the Office of the National Coordinator for Health Information Technology, ONC, all stand to gain by this type of initiative that will pump a certain amount of monies into, number one, the development of voluntary national research cohorts of 1 million or more volunteers. This will really gain better understanding of health and disease. We need to really pump some research into NCI to look at genomic drivers in cancer, to really apply that knowledge in developing more effective approaches to cancer therapy. The FDA, as I've stated, really feels an important need to take some of this information and have more appropriate pharmacogenetics. And then more and more we want to standardize across interoperability standards so that this data can be shared and utilized across different EHR systems, health information systems, et cetera, et cetera. So again, the initiative really is more embedded treatments for cancer, creation of a voluntary national research cohort, committing to protecting privacy. This is really important for my patients who are very concerned about privacy of the DNA data. Obviously, regulatory modernization is important, and then public and private partnerships has been the hallmark of genetics, even going back to the encoding of the Human Genome Project as well. So there's a really dual ambition of personalized medicine that we want to have both quality enhancement, which means to say early initiation of optimal treatments, trial and error of ineffective therapies should be avoided, but we also want cost saving. We want to reduce expenses. At the same time, we want to lower adverse events. We want to target prevention efforts. At the same time, have long-term cost reduction from disease prevention. So really, in the long term, we're looking for cost containment, but in the short term and in the long term, quality enhancement has to rule in this as well. And I gave this slide as an example that our friends at the University of California, San Francisco are working on projects, as are a number of institutions, to really take precision medicine into their day-to-day functioning. I don't want to leave our listeners unaware of whole genome sequencing, which is really reading the DNA sequence of an individual's entire genome. That is in the coding and non-coding regions as well. And this is more and more a part of what we've been doing in the world of genetics and genomics clinical applications. It does not, however, provide information on actual gene expression or epigenetic factors, but genome sequencing is a really big growing area of healthcare and genetics. Sequencing is easy, but bioinformatics is hard, and so more and more we are having to use mainframe computers to analyze the huge amount of data that comes out of this type of analysis, and the question becomes how to use this and how to properly incorporate this into day-to-day care, and that is really the kind of, I'll say, the Nobel Prize piece of genetics to get that accomplished. Pharmacogenetics, as I said before, is really a growing area where we use individuals' genotypic information, and we can look how the candidate drugs interact with a range of genes and biological markers. The point of this is that pharmacogenetics is not something that is futuristic, but it's here and now, and it's important. And why should we perform pharmacogenetic testing? Well, first of all, we want to identify the likelihood of adverse drug events. We want to be aware that there are likely 2.2 billion adverse drug events occurring annually, with over 100,000 cases might result in death, and we can do something about that with pharmacogenetic testing. We want to increase drug efficacy. 58% of patients who take prescription pain medications receive relief. If we can identify who has the right genes for the right medications, we can really, really make a big difference for our patients by doing that. We have patients who have reduced function alleles who have greater risk of major adverse cardiovascular events. For example, metabolizers of Plavix or clopidogrel, I'll talk about that more closely in a minute, becomes very important. We have patients who have psychiatric disorders, and low compliance and lack of efficacy can make a very big difference in these patients as well. We want to improve patient compliance. Certainly any physician worth their salt knows that what you think your patients take is not always what they really do take, and pharmacogenetics can make a difference with that. And then last but definitely not least, we want to reduce healthcare cost, and we can possibly save as much as $136 billion annually if we avoid these adverse drug events that occur using proper pharmacogenetic testing. Again, one size does not fit all. Pharmacogenetic testing will allow easier identify metabolizer status. There are really 5 genes in the body that we think metabolize over 75% of all medications prescribed. For those who don't think pharmacogenetics is important, I should tell you that all major drug manufacturers internationally spend a huge part of their budget, excess of 10, 15, 25% on working on the world of pharmacogenetics as they release medications into the market. There are currently 43 medications at least on the market that have black box label warnings due to genetic metabolizer status. Most aware would be codeine, Coumadin, Plavix, Coreg, Valium, and these are very important. And more some of the larger institutions I've listed below the slide are really taking it day-to-day into account. And I think, like I said earlier, the electronic health records of the very near future should more and more have pharmacogenetics in their algorithm so that physicians and other providers can be aware of this besides knowing the allergies and drug-to-drug interactions. Targeted therapy is something else to be aware of, that we are designing medications that can be targeted to certain somatic and germline mutations. This is very, very important, certainly today in the world of oncology, and it's also in other areas as well. So targeted gene therapy is a big piece of precision medicine. So stepping backwards a little bit, classification of genetic disorders. There are single gene disorders, there are chromosome disorders, and multifactorial disorders. And these are sort of one way to break down the areas that we are working on in terms of precision medicine. I always mention in every talk I give, both to the lay population and to physician community alike, about the importance of family history. Nobody should take away this webinar thinking that Dr. Palais is recommending purely and simply genetic testing. The first thing we do is a very detailed and a thorough 3-generational pedigree or family history. If you do that, If you find out from your patients when a grandmother, for example, had the diagnosis of a certain condition such as cancer, when they may have died, and you put that all together in a proper pedigree analysis, my genetic counselor colleagues and other geneticists like myself can really come up with the best recommendations for who should even consider possible intervention or what genetic tests may or may not be appropriate. And studies suggest that a well-detailed and properly taken family history can make a huge difference. In fact, the Genetics in Primary Care initiative done by the American Academy of Pediatrics, which I was a part of last year, really made it an important hallmark of pediatric history taking that could be important in these individuals. So a couple of thoughts about genetic testing. There are what I call focused genetic tests. In excess of 1,700 diseases and tests are available. And then there are predictive genetic tests. Some of these are looking for the possibility that someone would develop a certain genetic condition in the premorbid state. And so this is more and more becoming the focus of genetic testing. Yogi Berra said it's tough to make predictions, especially about the future, and that's more and more what genetics is about, trying to predict what will happen for our patients in a number of circumstances. So, for example, there are gene expression tests on the right-hand side, and there are genetic tests being based on individual DNA signature. And these are the classic tests that many of us have been aware of, but more and more now gene expression tests can look for the risk of heart disease, heart attack, the risk of things like a PSA rising in an individual for prostate, whether that may be an expression of cancer or purely a manifestation of older man's benign prostatic hypertrophy. So gene expression is more and more a key piece of the lexicon and the usage of genetic testing for our patients. Now, I've listed a few examples here, and I can't get to each one of them in this type of presentation, but there are a number of genetic markers that can be used for individuals that can help to have people know in general medical practice what might be important. Factor V Leiden, many of you have been aware of, is number 3 for venous thromboembolic disease. So when we have individuals who have an unfortunate VTE event, we can use Factor V Leiden to determine if such a person should be on certain medications or blood thinners, et cetera. As I said before, we can use for rising PSA number of 6. PSA is a PCA3 test for the right individual who can be helpful to know if a PSA is indeed a false marker or a valuable marker for that individual. And there are further examples we can go on from here. Now I'm going to focus in for a second on pharmacogenetics because that becomes really a key element of the precision medicine initiative. So CYP2C9 and VCOR-C1 are important for warfarin, one of the most commonly prescribed prescriptions in the United States. Over 3 million new warfarin prescriptions annually, and that number is not dropping as precipitously as one might have expected with the onset of a number of new medications such as Xarelto, et cetera, which are out there and are very important medications. But the problem, of course, is that there's a greater than 10-fold intrapatient variability in the response to warfarin. And so for these individuals, it can be important and leads to a number of admits and readmits to the hospital for patients who have problems with the use of warfarin. So the solution is you can do a simple mouth swab to determine if a patient is a poor, intermediate, normal, or rapid metabolizer of warfarin, and that can make a big difference to optimize dose, reduce side effects, including death, and have lower costs for repeat hospitalizations. In this slide, I don't want to get into any detail, but there's a number of dose adjustments that can be used based on the CYP2D6 phenotype, things like Sinequan, Norpamine, Pamelor, Paxil, Effexor, a whole host of psychiatric medications can really have benefit knowing what kind of metabolizer the patient may be. Now, there's a number of cardiac panels that can be looked at, looking for CP or 450 metabolism, and that can be used for platelet-inhibited metabolism, warfarin resistance, beta blockers, a host of things. Then there are genetic factors as well, looking at the condition on the right side, MTHFR, has been talked about more and more, and that has not been fully elucidated of its importance for day-to-day, but a number of my colleagues are looking at that and seeing if that's something that we should identify more and more. ApoE has been talked about for cardiovascular risk as well. So again, the number of these genetic markers are valuable for certain individuals based on family history, based on the right testing. I gave a couple of genotypic summaries as well, but I can't get into those in detail on this type of a webinar. So again, one of the classic presentations of the use of genetic testing is clopidogrel. It's an oral antiplatelet drug, as you all know, and obviously it's the second highest selling drug in the world. Its indications include for stent placement, recent MI, stroke, and peripheral artery disease. And the simple fact is that clopidogrel is often underdosed and can have poor clinical outcomes. And for individuals who are not properly dosed with clopidogrel, it can lead to stent thrombosis and significant events, which is very important that we don't have that happen with our patients. Now, before pharmacogenomics, we had clopidogrel responders and non-responders. After pharmacogenomics, we now look what we call poor metabolizers, intermediate metabolizers, extensive metabolizers, and ultra-rapid metabolizers. And, categorizing these patients is important, and this slide kind of identifies that for you. And a number of genetics testing facilities can do this for our patients. Again, it is in the black box warning for this medication. You should be doing genetic testing for patients on clopidogrel, and it really can make an important difference in the outcome of how these patients are handled and can, in many cases, avoid ADE or adverse drug events if properly done for these patients. Some companies, Percenogene is one of the ways you can report this. AI Biotech does that. We have also other companies, Companion Diagnostics, are doing this type of testing as well. Spartan Biosciences is a Canadian-based company that provides point-of-care genetic testing, and this small box can be placed in a catheterization lab, and a patient can arrive in the cath lab, and in the time they're having the procedure done and a stent placed, a nurse can take the sample, and by the completion of that test, you can have the result and be made aware of the kind of condition they have and what type of metabolizer they are for clopidogrel, so they're aware. Again, I don't represent any of these companies. I just bring them to your attention so you know they're out there. I don't have recommendations of one versus the other. Now, there are case reports going back to 2008, for example, a patient with major depressive episode. The patient failed Paxil due to worsening depression, was hospitalized and put on Effexor or venlafaxine, and then subsequently was diagnosed with resistant depression and put on clomipramine. Now, this patient had plasma levels found to be lower than they were expected, and so this type of individual can be found through proper testing to be an ultra-rapid metabolite. Pharmacogenetics. Now, there's known pharmacogenetic deaths reported back in Lancet 2006. A mother was given codeine for episiotomy pain after delivery, was later found to be heterozygous for CYP2D6 duplication, and thus she was an ultra-rapid metabolizer of codeine to morphine. This was found in the breast milk, and at the end of the day, this individual was found to be advised against codeine for nursing mothers. There have been other reports in pediatrics. In this example here, a 5-year-old girl who was taking valproic acid for seizures presented to her family physician with a cold that persisted for several days. The patient was given clarithromycin for ear infection and hydrocodone for cough, and this individual subsequently developed lethargy and dizziness, found unresponsive, asystole, and on postmortem blood screen was found that the patient had hydrocodone blood concentration 0.14, associated with fatality, and valproic acid level was in the normal range. So, we believe more and more that genetic testing for individuals can really subtype what type of medication and the proper dosing for them for these patients, and it could make a difference in outcomes, as in this case. There are studies working through a number of companies to use pharmacogenomics. Medicare has approved some of these studies. This is an example of a multi-site, single-arm trial that will look at a number of perhaps 2,000 clinical sites to look for adverse drug interactions and see whether patients can do well with intervention with pharmacogenetics 6 months after institution of that testing. Let's move into hereditary breast and ovarian cancer, an important area for use of genetics. About 7% of cases of breast cancer thus far we have elucidated may be due to inheritance. 10% of cases of ovarian cancer may be due to that as well. Many of us know about BRCA testing. I don't want to get into a long discussion about it because many of us are aware that it's become one of the key mainstays of treatment for patients who are high risk for breast cancer, who have breast cancer. I put the slide up mostly to highlight chromosome 17 for the BRCA1. This slide also has to do with about the patenting of genes, and Myriad, who is a wonderful company but did hold the patent. As many of you are aware, the Supreme Court ruled against the patent on BRCA genetic testing, and now there are as many as 14 companies in the market who are providing various forms of BRCA genetic testing. And my happiness about this is primarily that we have more and more availability of such genetic testing, which is the right one becomes a complex decision, which usually genetics trained individuals can do more for patients. But I want the physician community to be made aware that genetic testing, such as BRCA, should be made available to patients based on family history and is a key element of what I call precision or personalized medicine, because this can make a big difference in a woman's life. And Angelina Jolie has obviously spoken out publicly about this. Once again, she spoke about that in, yesterday in, I think, the New York Times, and her information that she's provided to the lay public is important to get people to step up and go to their physician and get help. Now, there's other uses of precision breast cancer using genetic predictive testing for recurrence scoring. Oncotype is probably the first one that came out from Genomic Health, and this is a test that looks for risk recurrence for early stage hormone receptor positive breast cancer, and this is becoming almost a gold standard. And there's a few others, MammaPrint, MammaStrat, and ProSigna that I've listed as well, that more and more are looking at as many as 70 or 58 genes to look at risk recurrence, and this is becoming a key portion of what I call the precision approach to breast cancer, so that physicians and other providers in the community who see patients who are diagnosed with breast cancer and treated who do not receive chemotherapy should be understood by our colleagues that that is the proper or the precise or the individualized therapy for that patient, because by doing so, that individual really will have a better outcome and won't be subject to receiving treatment that may not be helpful for them in the long run. So breast cancer can be utilized not only for the premorbid state, such as institution of tamoxifen for a patient with a positive BRCA who may not want to take more extreme actions, such as having prophylactic mastectomy, and they can be used BRCA testing in an individual who's diagnosed with breast cancer. And then these tests, such as Oncotype, MammaPrint, MammaStrat, ProSigna, can be used by testing cell block of tissue from the breast cancer to determine the proper or precise or precision therapy for that individual moving forward. So this is a good example of how precision testing can occur across the stratification of pre-morbid, existing disease, and long-term recurrence. Lynch syndrome is something that is also known as hereditary non-polyposis colorectal cancer. It is believed to be the most common of the hereditary colon cancer syndromes and accounts for anywhere from 3 to 5% of all colorectal cancers. There's a number of companies providing the test. One example is Colaris, but there's a number of other products that can look at disease-causing mutations and a number of the genes, and these can be responsible for the majority of Lynch syndrome cases. at several of our hospitals in the Atlantic Health System, we are doing automatic Lynch syndrome testing for any patient who comes in with a colorectal cancer diagnosis. And the reason is, even though it's not necessarily occurring in more than 5% of cases, but if we can determine that someone has this Lynch syndrome condition, then we branch out not only for that patient, but to their families, and really can identify, once again, in the premorbid or the non-existent state, who should have colonoscopy at an earlier age and who should have other testing and evaluations to determine whether this person may have in their family such a high risk of cancer that we can detect it at an early, more treatable stage, which is better outcome for that patient, better outcome for society, and lower cost as well. Once again, the usage of precision medicine in the taking care of patients works for everybody. Cystic fibrosis is something I want to touch on for a moment. Obviously, every person inherits 2 of these CFTR genes, 1 from each parent, and some of you are aware in this webinar that there's been newer therapies where we can work on the faulty CFTR gene to these patients and help make a difference and have a much better long-term outcome for these patients. So again, individualized, personalized, precise medicine being utilized, in this case with targeted gene therapy, can make a difference in the outcome of patients with cystic fibrosis who in our lifetime are more and more going to be able to live into their 40s, 50s, and eventually have a full life equivalent to their peers based upon genetic intervention for these patients. Alzheimer's genetics is a big issue that more and more we're looking at, and you know, there's a lot of public discussion about Alzheimer's disease. It discusses the bioethics. Should someone know if they're high risk of having Alzheimer's disease or not? That's a big discussion which has been looked at through such seminal works as the REVEAL study, through the New England Journal of Medicine. Bob Green's group up in Boston have looked at a number of cohorts of patients who have found that they do, in fact, want to know whether they are at high risk of Alzheimer's disease based upon their family history and other genetic testing. The problem we have is that, you know, can we do something to identify someone having a more likelihood of getting Alzheimer's disease, and if so, can intervention be taken for these patients? Well, again, it's my hope that the precision genetic initiatives that the national government are trying to fund will look at more and more techniques at how to handle these patients. There's been a recent release of a drug that may have good efficacy at early stage Alzheimer's disease. So again, the question is, how do you find these patients? Well, family history is one thing. There's a whole difference of early onset disease, EOAD, versus late onset disease. And then there are markers, presenilin, amyloid precursor protein, that may or may not become more useful in day-to-day clinical use. ApoE4 has been talked about, but may not be a really precise indicator for these patients, whether one is heterozygous or homozygous for that particular ApoE4 gene. But I think the point to be made is there are patients who want to know, based on their genes, whether they are indeed likely to have Alzheimer's disease as they age. And so we in the medical community are needing to research for this, you know, very devastating illness and find ways to identify patients perhaps in a premorbid state so they can possibly have either early intervention by diet lifestyle changes and or by the use of properly ordered medications when appropriate. Now, cardiac genetic areas are something also that's important. I mentioned before, pharmacogenetic, such as clopidogrel or warfarin can be important, and these are ways to look at drug-based genetic variants. But then there are diagnostics examples, such as long QT syndrome or cardiomyopathy, where it can be important to do genetic testing in the right individuals, people having a sudden death in their family or cardiomyopathy conditions. We have also to look at predisposition. Obviously, coronary artery disease, hypertension are fairly ubiquitous in the population, and any intervention that could possibly have a positive impact could be very important to have a long-term improvement of morbidity and mortality for our populations. And so genetic testing is helpful in that capacity as well. I'll give as an example is Chorus, a recently released gene expression test. And you remember earlier in my presentation, I talked about DNA genetic testing versus RNA testing. So in this example, Chorus is a gene expression test that will take an algorithm comprised of the expression levels of approximately 23 genes to demonstrate if someone has the likelihood of obstructive coronary artery disease. Bottom line is that if more and more the cause of heart attacks could be on the basis of inflammatory disease, if we can measure the messenger RNA signal and find people who have a higher result for this, these people need more intensive, more aggressive investigation through such techniques as cardiac catheterizations, whereas their peers who have a lower test result may not need such intensive investigation because their cause of symptoms of chest pain may have nothing whatsoever to do to coronary artery disease. So a test such as this one using messenger RNA gene expression can be helpful in the front lines of primary care to do what I call risk stratification and could end up pointing some people for invasive evaluation and others may not. And that could be, again, an important save for patients in both terms of morbidity, long-term mortality, and cost as well. And this is something that the usage of precision medicine, once again, is likely to be of great assistance in the current and not too distant future as well. It's important to note that actually this is approved by Medicare, and so there is importance to consider this in the armamentarium of both primary care physicians and cardiologists in handling their patients with heart disease and chest pain symptoms. Again, I don't represent this company. I just give this as examples. The cardiac channelopathies, which I said before, long QT syndrome, the most commonly talked about. It's rare. Looking on the bottom of the slide, it's in 1 of 5,000 individuals. However, it's catastrophic. It leads to sudden death in many individuals. It can be found on proper screening with history taken for these patients, as well as having EKG evidence of a long QT syndrome. But if you can find these patients and identify them, you can, again, categorize them, and these individuals can have interventions as simple as having no startling alarm clocks at their bedside to save their life, or sometimes have an internal defibrillator that can also make a big difference. And this is, once again, the right therapy for the right patient or the right time, such as what we call precision or personalized medicine. Now, there are legal issues, as I stated before, related to genetics. The GINA, or Genetic Information Non-Discrimination Act, is important for my listeners to be aware of. It does prohibit U.S. insurance companies and employers from discriminating on the basis of information derived from genetic tests. So this is helpful, and a lot of patients are happy to hear this exists. It does not, however, apply appropriately for long-term care insurance or life insurance. So the question of whether that is an area and more we need to protect patients who seek out genetic testing for risk stratification scoring. That has to be discussed. I think California has been very proactive in this particular area, but I think that right now the key is that patients should not be scared of having genetic testing when they want to look at their risk scoring, because this is helpful to them. It's no different than when one gets a cholesterol in a healthy state of mind at age 40 to try to ascertain the possible risk of long-term heart disease using that well-documented and well-substantiated biochemical marker. Well, in the same way, genetic testing can do something like that, but the difference is we shouldn't use genetic testing adversely for patients and should try to have that information be helpful to them as they make long-term decisions for diet, lifestyle, and medication interventions when appropriate. So precision genetic testing saves lives. That's really the bottom line, and I hope this presentation has helped listeners to be aware that there's a number of things that one can do, both from genetic testing, risk stratification, and especially in the world developing of pharmacogenetics that makes a big difference. And this is where the initiative that President Obama has brought forth in his State of the Union is exciting to us in those of us who work in the genetics field, because by having more focus on this, both politically, economically, by having large million-person cohorts made available with very strict, careful data integrity, we can be sure that our patients are going to have a lot of valuable information that can be utilized across the population, something we call epigenetics, so that patients can arrive at a better care for themselves, their loved ones, and their future generation. So at this point, I think I'm going to look for questions if anyone has them, because hopefully you've had an overview of precision medicine, pharmacogenetics. And Dawn, I'll hand this back to you right now.
Great. Thanks, Dr. Pale, for the fabulous presentation. It was really extremely informative. We have a bunch of questions that have come in, which I'll get to in a moment, but would you like us to show the video first, or did you want to do the questions first?
Yeah, I think that would be helpful. If people want to see the video for a second, that'd be great.
Okay. So I'm going to let the team switch it over to the video. So do you want to just describe the video while we're turning it on?
Yes, so the video is just a nice piece taken off the whitehouse.gov website, and it's only a minute and a half, and I think it helps to provide a visual display of the future applications I was discussing in my presentation of precision medicine as it can be used in the world of research and clinical medicine.
Okay, here we go.
Precision medicine is an exciting new area of medicine that allows us to use cutting-edge technology to match patients with the treatments that will make them well. Precision medicine gives us the tools to say what makes each of us different from everyone else. And that's a mixture of our genes, the microbes that live on us and in us, environments that we live in, and all the factors in the environment that we're exposed to, as well as our diets. All of those things come together to determine how healthy or unhealthy we are. And the power of precision medicine is beginning to interpret what factors will affect an individual's health or susceptibility to disease. We have technology now that can sequence the human genome quite rapidly. That means we can get a sequence or the alphabet that forms the gene for every single trait in the human body. Precision medicine is now. We're already using it. It's already affecting people's lives, and we know it works. But if we can expand it to cover lots of different disease and health characteristics, we will be able to treat all sorts of diseases that we have no idea how to tackle right now. So the future of precision medicine is enormous. This is a revolution in medicine. I am so excited to be here at the White House working on this initiative because I think this is one of the biggest things to happen in medicine in a very, very long time and will really make the future health of people in America totally different.
Great. Well, thanks for sharing that with us. So we're just going to go back. If you guys could, yep, perfect. So let me just jump into the questions here. So the first question is, can you provide a little bit more detailed information about the Oncotype DX and how it works on breast cancer cases?
Okay, do you hear me?
Yep, we can hear you.
Okay, good. So Oncotype, and again, is just an example of one of the frontline tests that was released now 8-9 years ago at least. And what it is it looks at about 23 different genes on the breast cancer tissue in early stage 1 breast cancer, and now also can be used for DCIS as well. And look at these genes, they can really come up with a risk scoring process. And if an individual, if a woman has a high risk score, she is likely therefore to have a recurrence of breast cancer, and therefore when the medical oncologist and her medical team make a decision about whether she should receive chemotherapy, she likely could respond and likely would be a good candidate for chemotherapy. On the reverse, if someone has a low risk recurrence score based on those genetic markers, then to subject that individual to having chemotherapy, which in and of itself has long-term problems such as possible developing of leukemia lymphomas from the usage of chemotherapy, not to mention the morbidity of hair loss, nausea, et cetera, et cetera. So when you take risk-benefit ratios into account, that individual with a low-risk score oncotype is someone who should probably not receive chemotherapy. And so that is a decision that has tremendous implications for obviously the individual and receiving chemotherapy or not, for their medical providers, and not the least of which for the insurers who would be spending $150,000 plus for care, which a genetic testing oncotype could make a huge impact for a much, much less cost. So it really is a perfect example of better care, individualized care for that patient based on genetic markers, and also having long-term cost reduction if someone were to not require chemotherapy.
Great. Well, thank you for that answer. Okay, so I'm going to move on to the next question here. Is precision medicine just a fancy title for boutique medicine?
Okay, well, I hear that every so often, and I certainly hope those who've been on this webinar do not see what I just presented was boutique medicine, because this is, as you can see, highly rigorously scientific, rather complex. Not to say that boutique medicine is not an important area for those who decide to provide that, but boutique medicine certainly looks to provide individualized care, but not necessarily using high-level genetics and genomics and all the things I described on this call. Let's put it this way. Precision medicine is a semantic terminology, but it takes into account detailed history, detailed family dynamics, and very precisely ordered appropriate genetic testing. Boutique medicine is a way of providing more personalized care. In fact, many boutique or concierge companies like to use genetic testing in their care. But I hope, again, it's clear that this is not boutique. This is not something that connotes, frilly type of care. This is rigorous, scientific, somewhat complex, but extremely important, and in the end of the day will arrive, I believe, and I hope I've made it clear in this presentation to everyone, that the end result will be better care, more effective care, and more personalized care for people so that they don't have those unwanted adverse outcomes, both medically and in terms of drug adverse events as well.
Great, thank you for that. The next question is, isn't genetic testing too expensive and not generally covered by insurance plans?
Well, that's a commonly asked question of me, and look, it's not something that is necessarily inexpensive, although some tests are not as expensive as we may all think. Certain bracket testing may be in the order of $3,000 to $4,000, which is a lot of money, but when taken to the context, it can make a decision long-term for possible prophylactic mastectomy or possible institution of other therapies or providing use of tamoxifen before a cancer even develops. If you take it in the proper context, I don't know that the $3,000 expense for bracket testing is even all that expensive when taken into the full context. But having said all that, here's the key about cost of genetic tests. Genetic tests should not be done for everybody and should not be done willy-nilly, but it should be done for patients who need it with the proper and appropriate reasons. And if we do such testing, first of all, the cost has dropped precipitously. So doing full genome sequencing for James Watson, as in Watson and Crick, the founders of DNA, that was in the range of several $1 million. And doing full genome sequencing has dropped, in the $10,000 to $15,000 range or less. That is a rather significant drop and is probably going to drop even further. So genetic testing has become more available. It's not something for just the high-yield individuals these days. And I think that I hope in the near future genetic testing becomes more routinely covered, as I showed you in the slide about the perfect storm we're living in. And we get genetic testing in my genetics center for people on Medicaid who have autism, who need SNP microarrays looking for the sources of their autistic conditions, and we're able to get that covered for them. So I wouldn't like listeners to think that we're just doing testing for people who have high influence or money. We're doing this for anyone who needs it, who has the right indications, and I think that it should be available and paid for when appropriate, not when it's inappropriate. Thank you, Dawn.
Great, thank you. Terrific answer. And the next question is, how reliable are predictive genetic tests?
Okay, you said hitting me with all the big questions that people ask me about. So predictive genetic tests, and I gave several examples during my demonstration, are important, and we need to differentiate predictive tests. BRCA testing is in and of itself considered a predictive test because we can get that in an individual, a woman who could be in their 30s who has completely normal mammograms and no breast lumps, et cetera, and so we would all say that has been a well-substantiated predictive test. On the reverse side, when you talk about certain SNP tests where we take large cohort populations, some of the best examples have been done in Iceland, where they have multi-generational family histories coupled with certain genetic testing that mainframe computers can try to state that there are 9, 12, or 15 markers in that family history, and they all seem to point towards the likelihood that that person, for example, might have prostate cancer, as an example. Well, the simple reality is that those predictive tests are valuable. I think they're a piece of the healthcare puzzle we use, but you should not get such a test and think you will indeed definitively get, in that case, prostate cancer. But certainly if you have such a high propensity or risk towards that based on these genetic markers, then get better care, get more intensive screening for that. In such a case, digital rectal exam and other markers could be particularly valuable. So I like to think, Dawn, predictive genetic testing is not only diagnostic in some cases, but more than that, it actually can be a motivator for better health care for those individuals. Indeed, if you have a higher risk of Alzheimer's based on family history alone, and maybe if it's coupled with genetic markers, well, then you're an individual who could benefit from the numbers of things that have shown that could have impact on better health. And if you do those things, you might put off the onset of Alzheimer's, or you might institute earlier therapy for that condition. But it is absolutely correct for those who would state that some predictive tests do not mean cause and effect 100%. Now, that is opposed to genetic testing for conditions such as ALS or Lou Gehrig's disease or Huntington's disease, where if you have the genetic default for that condition, you will 100% have that. So from a bioethical model, nobody in genetics recommends those individuals people be screened for that in the absence of any symptoms, because that is, a kind of a death sentence of sorts. By the same token, in the pediatric range group, under 18 years old, it has been very clearly recommended that we do not do generic across-the-board genetic testing in children for conditions in their adult population, particularly if it's not clear-cut that they may or may not even have that condition. So genetic testing is very focused, particularly on the pediatric population and in certain neurologic conditions when we're not sure which way things are going. It's complicated, but I hope I've been making my answer clear to you, Dawn, that risk testing, and some of the direct-to-consumer companies do some of these risk testing for genetics. They should not be taken as 100% accurate, correct?
Great. Well, thank you. That's an excellent answer. And things, I think, have really progressed in just a few short years at setting out some of those recommended protocols that you're mentioning on what should and shouldn't be done on a regular basis. So thanks for informing our audience about that. That's fabulous. Again, encouraging more people to submit questions, but I'll move on to this one here. What is the future state of electronic health records and better family history, and therefore the possible algorithms to suggest that people have genetic tests?
That's a complicated question. Someone who must be working on the EHR systems. So, electronic health records has been something that's becoming more and more commonplace in physicians' offices and hospitals as well. And they are really invaluable tools towards, aggregating data and helping us to have a better understanding of patients' conditions and also propagating it to other physicians and sharing the data. So in the world of genetics, and I hope I'm answering your question correctly, electronic health records more and more the more sophisticated systems can really look at data that's input and look at, family histories in particular. Like I said in my earlier slide, you want to take a 3-generational family history with a lot of detail, particularly to the onset and specifics of that condition. And if you put that all together, a number of institutions, I should mention not the least of which Cleveland Clinic has been working with Epic, because we've been working with them at Atlantic Health as well, to try to come up with an algorithm model where if you enter certain data, it can make some suggestions that, did you consider, BRCA testing for this person? Did you consider LINS testing, et cetera, et cetera? So I think that in the not-too-distant future, if we can get more uniformity of electronic health systems, not that they all have to be the same, but we can have exchange of data through HL7 connections, et cetera, and the Affordable Care Act, as well as the Precision Medicine Initiative, I think are looking more and more to find standardization. So if we have these histories and if we get genetic testing, we can put this across the system. So I, as a family physician, and someone as a general surgeon, and someone as a medical oncologist can be looking at the same history on a detailed basis and the same genetic information and arrive at a much more carefully proper treatment plan for that patient. And also, in some cases, we can write in software using, as you say, algorithms, so that we can make suggestions. Because, we're not going to teach all providers, all physicians, nurse practitioners, and PAs in the United States how to know genetics. But what we can do is make proper suggestions for them. And that already happens in a number of ways for patients at a medical home, where we suggest, did you consider cholesterol testing? Did you consider, hemoglobin A1C for diabetics? So I look forward to the day when genetic testing is part of the same armamentarium for our patients. Thanks, Dawn. Good question.
Great. Great. Yeah, I can see a terrific future. Just want to let everyone know that there is a survey, a quick survey in the Dropbox, and while you're listening, if you could just fill that out, we would really appreciate it. You do have quite a number more questions, Dr. Pale, so since we are recording this, we're going to go on and ask you to answer the rest of these questions so that people can listen to it afterwards. But I do recognize that it is the top of the hour and some people may need to leave. So if you can hang on, that would be great, but we'll continue to finish these questions. So are saliva specimens accurate in testing environments?
Well, they're accurate insofar as they're properly obtained, and if they're done properly, and any good genetic testing company will know when they get the sample if that's done. I have a personal bias. I tend to prefer blood specimens because then the tissue, which blood is a tissue, is 100% could be certain. But the simple fact is that many facilities don't have blood drawing available. Some people are squeamish about it. And saliva is an alternative that a number of tests can be done one way or the other. And I don't object to it, but there'll be no doubt that when the sample is sent off, there are occasionally cases where the saliva could be insufficiently obtained, and that simply means that the specimen will be insufficient and the lab will inform the provider as such. So no one should be against doing saliva testing. If you do it, it's good. If it's insufficient sample, you don't get enough cells off someone's cheek, inside their mouth, then you won't be able to do it. But that is actually a small minority. So most genetic testing companies are happy to process saliva or blood either way.
Okay, great. Thanks so much for that. The next question here is, can't insurance companies use genetic testing against patients? And I think you answered that a little bit, so you might want to just...
Yeah, I answered that in the GINA, the Genetic Information Non-Discrimination Act of 2008, which was actually signed into law by President George W. Bush. It was a bipartisan piece of legislation, and so that is helpful. It's not ironclad, so do I think it's possible that genetic testing could be used for certain predictive outcomes, such as long-term care insurance, for example? Yes, it's possible, but by the same token, that testing is being done, HIV testing and other cholesterol analyses are hallmarks of actuarial analyses insurance companies utilize, and we all know that those are never 100%. So two people who know each other both get their cholesterol checked, and one person has high cholesterol and lives a long life. The other one has normal cholesterol and collapses from sudden death from other reasons. So, you know, the insurance industry is an industry of actuarial science, and they're going to use whatever pieces of information they think they can. If they think genetics are appropriate, I would argue that they have a right to do so, but I prefer that they not use it as a gold standard, because I already said in some cases genetic testing is not always ironclad when you're using the predictive types of SNPs that may or may not always stand up to time.
Okay, great, thanks. This one I think you've answered a little bit as well too, but in case you want to expand on it any further, should kids be tested for predictive genetic tests?
No, no, no. In my opinion, I think that would be a bad thing to do. I think the better question I get sometimes, so now someone's 18 or 20 or 21 and they're of emancipated age, should they be tested? And again, I think that, you know, like many things, and my first love is primary care besides doing genetics. I don't know that a 21-year-old has to have their cholesterol checked in the absence of a very, very strong family history. But if they do have a such strong family history and they're 21 years old and they're concerned, it's not a bad thing to make them aware of it, but I don't think they should necessarily spend their whole life with a, shall we say, sort of Damocles over their head, worrying about their long-term when they're only 21 years old. So in a similar fashion versus biochemical markers, that being cholesterol, should a genetic test be taken 21 years old to look at risk of prostate cancer? It's kind of hard to believe that's really the right way to use that type of thing. But what is the right age? 21, 30, 40, 50, 60. It's hard to say. It's probably something that's based upon that own individual's unique interest and how aggressive they'll take action on this. If you take a genetic test and plan to do nothing about it, well, then maybe it's not valuable to do it. But if you can take a genetic test with the intention on predictive testing, that is, to do something about it, whether it's instituting medication or diet or lifestyle or earlier screening by modalities such as radiology or endoscopy testing, well, then it's certainly appropriate at an earlier age, but not in the pediatric population. So I would like to say that's not where we want to go with this. Thanks, Dolan. Good question.
Great, thank you. Yeah, it's kind of, I like your thinking about, you know, if you're going to do something, then, you know, yes, maybe think about it more seriously. It helps us all get more proactive for our healthcare.
Right.
So next question is, aren't most people afraid to know their genetic test results? Or did I just ask that? No, sort of you just answered it.
Yeah, I think it's a knee-jerk response. Some people per second, but studies bear out that a high number of patients do in fact want to know when they understand the context of the usage of their genetic information. So I think more and more I'm seeing people are interested and they want to know more about it, and there's a small subpopulation of people who don't want to know. In fact, certain testings, you have to answer questions and agree to information being revealed to you, and that's fine. Again, I never want to force genetic testing on anybody. I always want that to be available, particularly in the healthy population. When we discuss, you know, predictive testing, no one should get that unless they want to know about it, and they should not take the information and put it out of context. Like I said, if you get a cholesterol and it's over 300 and you're 25 years old, you shouldn't get crazy about that, but you should say, that's interesting. I need to do something about that and do something about it to make an impact. But you shouldn't take the genetic testing the wrong way. Otherwise, it's not being useful to you. You don't want to have it come back around and be the cause of anxiety or depression, and that's not something we want to have happen here.
Great, excellent points. Thank you. What about the direct-to-consumer genetic testing and the FDA shutdowns like for 23andMe?
Well, that's a complex area because, you know, certainly the public has the right to get certain testing if they choose, but in this case, you know, the FDA, I think, took appropriate action that when certain direct-to-consumer companies were out there and offering testing, in some cases the information could not be properly vetted and the information is not always easily able to be understood by patients. There was never a question of the quality of the testing done. The quality of all these direct-to-consumer companies is really quite appropriate. They use similar gauge machinery and testing than standard genetic companies will do. The question really is the interpretation of these results becomes uncertain. So right now, some of the companies are reemerging and trying to provide, in some cases, raw data for patients to look at, and the data can sometimes be analyzed by secondary companies. But I caution people that we in our genetics center here at Atlantic in New Jersey have had cases where sometimes the interpretations have not always been thoroughly vetted and reproduced when we've done this with other companies as well. So like all things in life, a tinge of caution, but direct-to-consumer testing can be valuable and can be one piece of the puzzle for some people who really want to know a lot about it, but they just should probably take the information and clear it through a genetic counselor or a genetics-based physician who can make sure the data that's presented is both accurate, appropriate, and properly analyzed on.
Great, thank you. So I have one more question for you, so I'll just take this as a reminder to anyone. If you have another question, to just send it in, and then we could have two more questions. But we'll go to this last question and then do a bit, just a closing remark. So how accurate are these pharmacogenetic tests?
Well, they're accurate insofar as they look at the information and the genetics can tell us how a drug is metabolized. That is accurate. The question becomes, can it be utilized, and is it cost-effective in its utilization for patients? And a lot of studies, as I mentioned, are looking at that right now. A number of them are approved by Medicare and FDA, et cetera, looking to analyze if we can be more cost-effective and more precise and really come up with this is an individual and they respond best with this drug versus that drug. So I think the answer is yes, they're precise. I think they're valuable, and I think they can make a big difference. What we really have to see is long-term, will it be something that the general medical community can make use of more routinely? I wouldn't want to see someone living in the East Coast moving to the West Coast and getting those tests repeated, because that would be inefficient and too costly. But I do believe that when a psychiatrist prescribes antidepressant medication, anything you can use that could be helpful to hone in on the right medication is highly valuable, and I think that will become important in the future prescriptive patterns of physicians, be it pain management, psychiatry, cardiology. I mentioned numbers of examples in the presentation. So I'm excited about pharmacogenetics. I think it really will become important more and more in the future, and I think that a number of institutions, well-known national institutions, have already used this, and I think the risk of these adverse drug events, if they drop even by a fraction of what I showed in my slides, it foreshadows, a huge amount of improvement of life and a great deal of cost reduction for the healthcare system, which is overtaxed as it is. Thanks, Dawn.
Great. Well, thank you very much. And I just want to remind everyone that we are recording this webinar, and we will place it onto our website, so that if you'd like to listen to this after the fact, or if you'd like to share it with colleagues or other people that might be interested in it, it will be up in the next day or so. So just a great big thank you to Dr. Arnold Palais. I've put up here his contact information if you'd like to contact him further for any follow-on. We also would be very interested in having people listening to this. If you're involved in this area of healthcare or in other areas of healthcare life sciences, we do offer these webinars free of charge, and we are looking for other people working on the leading edge of life sciences and healthcare and new solutions for patients and the healthcare system. So we offer that to you to contact us directly if you'd like to be a future speaker. So terrific presentation today, Dr. Palais. So we just wanted to say thank you so very much, and really appreciate it. And we hope to hear back from you again soon in a future webinar.
Thanks, Don. I appreciate having me, and I hope this was not too difficult or convoluted for your listeners to follow. But my recommendation, keep your ears and eyes open. I think that with the initiatives that the administration has put forth, I think in the next 2 years, you'll see a lot of real exciting improvements to healthcare that I think will make us all more efficient and better providers, and will ultimately have better outcomes for our patients. So again, I thank you for having me present today. Have a great day.
Thanks, everyone, and we look forward to having you join us on future webinars. Take care now. Bye.
Thank you.